Have you ever wondered what happens after a child sustains a community needle stick injury? What factors determine their hepatitis B post-exposure prophylaxis? The truth is, it is so variable, and the decisions that we make impacts the child, the family, and has significant cost implications. It is time we re-examine the hepatitis B post-exposure prophylaxis in the era of a national immunization registry. Now, my name is Chris Yu, and I'm a pediatric infectious diseases and a microbiology registrar in Perth. I'd like to begin by acknowledging the traditional custodians of the land, the Noongar Whadjuk people, and pay my respects to the elders, past, present, and future. Community-acquired needle stick injury in children generates significant parental concern, despite only 2 cases of hepatitis B transmission reported in the literature in this setting. The recommendations for hepatitis B post-exposure prophylaxis are inconsistent both nationally and internationally. In some countries, hepatitis B immunity is assessed based on prior hepatitis B immunization history. In other jurisdictions, such as Australia, the guidelines vary but predominantly recommend measurement of hepatitis B surface antibody to determine immune status. When using serology as a marker of protection, individuals with hepatitis B surface antibody less than 10 international units per liter are recommended to receive hepatitis B vaccination and/or hepatitis B immunoglobulin. Then, a follow-up at 4 to 6 weeks and 3 months is required by an infectious diseases specialist or a GP that is skilled in this area. It also involves significant coordination of time, resources, in addition to anxiety of a blood draw or more vaccines, as well as anticipation of the results. We looked at all children presenting to the Princess Margaret Hospital or Perth Children's Hospital following community needle stick injury from 2014 to 2019 and had hepatitis B serology performed. We excluded those without community-acquired needle stick injury. We used the Australian Immunisation Register to obtain information on vaccination status and compared this to serological markers of hepatitis B immunity. We also wanted to know how easy it is for patients to follow recommendations provided by their doctors by assessing the compliance to hepatitis B vaccine and/or immunoglobulins. Finally, we looked at the rates of blood-borne virus infection at follow-up, as well as the projected cost savings using the current practice of using hepatitis B serology as a marker of immunity versus immunization status that's based on the Australian Immunisation Register as a marker of immunity. We identified 56 children with community-acquired needle stick injury. Of those with immunization records, all had completed hepatitis B vaccinations. At presentation, 42% had hepatitis B surface antibody less than 10 international units per liter, and this was more likely in older children, more than 6 years, compared to younger ones. Hepatitis B immunoglobulin and vaccine adherence was only 65% and 78% respectively. All children who had serology performed at follow-up more than 4 weeks following the vaccinations or hepatitis B immunoglobulins demonstrated an amnestic response. Importantly, no hepatitis B infections were detected. And finally, our cost analysis showed that using immunization status based on the Australian Immunisation Register versus hepatitis B surface antibody levels as a marker of immunity to direct post-exposure prophylaxis resulted in a projected cost savings of more than 4,000 Australian dollars. I'd like to conclude with a few points. In children, immunization records are well documented on the Australian Immunisation Registry. It is easily accessible and allows us to purposefully utilize current technology to direct management. Secondly, we know that despite waning hepatitis B surface antibody levels over time, there is persistence of immunity and high rates of anamnestic response, as demonstrated in our study and also in the literature. Finally, there are significant cost savings when using immunization status based on the Australian Immunisation Register as a marker of immunity. We must encourage re-examination of the current hepatitis B post-exposure prophylaxis following pediatric community-acquired needle stick injury, especially in the era of a national immunization registry. Please leave us some comments or questions. Thank you.